Good afternoon. The subcommittee will come to order. Today we're going to do a deep dive into another dysfunctional area of the Oracle Cerner EHR instability of the system. VA and Oracle have come up with many different words to describe this problem. Outages, downtime, incidents, performance degradations, user interruptions, and incomplete functionality. They all mean that the EHR isn't working and that staff can't use it. That's the bottom line. Far too often the EHR amounts to a multi-billion-dollar frozen screen or a brick on the employee's desk. When the system goes down, the veteran's exam gets interrupted or delayed. Or the provider has to document orders on paper and enter them into the system later on. Sometimes the procedure has to be postponed altogether. And we all know what kind of problems that presents by postponing these procedures. In at least a dozen incidents, some sort of EHR outage directly contributed to a close call or patient harm. It's an unacceptable situation. Finger pointing and blame shifting between VA, DoD, and Oracle have gone on for far too long. We're going to delve into the numbers as well into the root causes here today. According to VA and DoD, incident free time under their control was between 95% and 99% this year. And according to Oracle, incident free time under the company's control was between 87% and 97% during the year. It is true that complete nationwide outages have become less and less common over the past year. But crashes, hangs, and errors that affect one facility, one module, or one person are still widespread. Ultimately, what the users experience is what counts, and they are not happy. The KLAS class research surveyed VA employees about whether, quote, over the past 2 weeks, the EHR was available when I needed it and downtime was not a problem, end quote. Only 26% of VA employees agreed with that. And 58% of the employees surveyed said that EHR was not available and downtime was a problem. There is a big disconnect here. Either by design or by accident, the criteria VA and Oracle are using are clearly not capturing all of the system's problems. We know that the EHR help desk ticketing process makes VA staff jump through hoops to report issues. The Office of the Inspector General audited the help desk last year and found widespread frustration. Many of the employees have simply given up reporting the glitches that they encounter. So truly, the numbers are worse, much worse than what Oracle or VA is reporting. Finally, the VA leaders told us 6 months ago that they had renegotiated the Oracle contract to focus on improving the EHR's uptime. They told us that they had added tough service level agreements and real financial penalties. The results don't seem to bear that out. I'm not seeing much motivation. All in all, the statistics we're being given are vastly different from the independent data that we have and from what we are hearing from the medical centers themselves. I appreciate our witnesses joining us today to explain this. With that, I would yield Ranking Member Shirflis McCormick for her opening statement.
Thank you, Mr. Chairman, and thank you to the witnesses for being here today. While I agree that stability of VA's new EHR is a critical part of the success of this program, I'm concerned about the fact that we have to spend so much time talking about it. It seems to me that an operational EHR is the minimum requirement. It's the very least that we should expect of Oracle Cerner and VA. I've received the data about Cerner and VA-owned downtime. I'm concerned that the data doesn't seem to match what we're hearing from frontline staff. The end users that we have heard from indicate that the system is frequently either slow or non-functional, and that other systems that interface with the EHR, such as JLV, are even worse. Transitioning to a new EHR is always hard. It doesn't need to be made harder by a system that isn't reliably there when you need it. I find it especially problematic that we are still talking about system stability more than 3 years after the initial go-live at Mann Grandstaff VA Medical Center. These technical gaps should have been identified and mitigated prior to the system go-live at Mann Grandstaff in October of 2022. The fact that there were and is still a huge disservice to the staff and veterans at the facility. In addition to the inherent stability issues, we have heard repeated stories of Oracle Health pushing updates that break other functions of the EHR, and that in many cases, they're pushing these updates in the middle of the workday. This doesn't seem like best practices to me. These updates would be safer if they were pushed in the middle of the night when their impact would be less felt. I hope to hear today now how VA and Oracle Health are working to improve this process. For over a year now, we've heard from Oracle that they're making major improvements to system stability, but there seems to be a lot of finger-pointing between the VA, DoD, and Cerner. I'm pretty sure frontline staff don't care who is responsible. They would just like for their issues to be fixed. I hope to hear today how VA and the FEHRM firm plan to do just that. Finally, I'm bothered by the fact that we're forced to spend so much time talking about this when VA and Cerner have much greater, much bigger, and more complicated issues that need to be addressed. It seems that since Oracle bought Cerner last summer, it has attempted to focus on the EHRM conversation on improving system stability. I guess they would rather talk about this low-hanging fruit than talk about fixing the clinical workflows, or the fact that training and change management are still woefully inadequate and user satisfaction is still critically low. I am disappointed that Oracle Health isn't here to participate in this conversation. I understand that Ms. Scalia had another obligation, but there must be someone else in the organization that could speak to this topic. It is very disappointing, I would like to stress, that they're not present with us today. The fact that they didn't send a representative raises major concerns for me, and I expect better. I'm constantly losing faith in the process. With that, Mr. Chairman, I yield back.
Thank you very much, Ranking Member Surplus McCormick. I will now introduce the witnesses on our first and only panel. First, from the Department of Veterans Affairs, we have Assistant Secretary for Information Technology, Kurt Delbenny. We also have Deputy Chief Information Officer, Laura Pratula. Finally, from the Federal EHR Modernization Office, we have Director Bill Tinston and Chief Technology Officer Lance Scott. I ask the witnesses all to please stand and raise your right hands. Do you solemnly swear under penalty of perjury that the testimony you're about to provide is the truth, the whole truth, and nothing but the truth? Thank you very much, and let the record reflect that all witnesses have answered in the affirmative. Mr. Delbenny, you are now recognized for 5 minutes to deliver your opening statement.
Good afternoon, Chairman Rosendale, Ranking Member Sherfullis McCormick, and distinguished members of the committee. Thank you for the opportunity to testify today in support of VA's initiative to modernize its electronic health record system. I'm accompanied by Dr. Laura Pratula, Deputy Chief Information Officer of the Electronic Health Records Modernization Integration Office. I want to begin by thanking Congress and the committee for your continued support and shared commitment to veterans, more specifically to your support for the VA's EHR modernization efforts. For VA, the successful deployment of the federal EHR system will facilitate seamless healthcare transitions for service members and veterans across federal care settings. As this committee already knows, the federal EHR will provide an accurate lifetime health record for veterans among partners using the federal EHR. Most excitingly, for the newest members of the military, the EHR will serve them from the day they begin their military service through the rest of their lives. VA is on a journey to implement this large system transformation here. The federal EHR system is a highly complex software environment composed of the core medical records system and several other connected systems that together deliver the overall EHR experience to clinical providers and patients. In February 2022, VA established the Performance Excellence Program to improve the overall system performance, resiliency, capacity, and reliability of the Oracle healthcare system. With this systematic approach, we've seen the core system stabilize over the time period, resulting in an improvement in the overall user experience. As of November 8th, there have been 185 consecutive days without an outage, and 100% system availability in 10 of the last 12 months. To be sure, we're still experiencing partial system failures that impact the users. We capture these in our incident free time, or IFT, which measures the time that the system performs without significant end-user problems. While the IFT metric is improving, it is not yet meeting the service level agreement of 95% IFT on a regular basis. As of September 30th, 2023, Oracle Health has reached this metric only 4 of the past 10 months. This partially is from the number of changes that are being introduced. It's a well-established axiom of software development that systems stabilize when the rate of change made in the system decreases. The rate of change is still very high, resulting in more incidents than we would like. In some cases, the VA has requested functionality that has never been deployed in Oracle Health commercially, such as the integration of VA's consolidated mail outpatient pharmacy, making VA the first user of this functionality, which also increases incident risk. Regarding end-user support, we have improved the processing of tickets, and Oracle Health has met all 4 ticket management SLAs in January, August, and September. Every critical and high-severity incident has a root cause analysis done and a preventative action identified. These reports are now integrated into OIT's daily operational status review. Ultimately, we anticipate that the system's performance will improve when change velocity decreases, and enough time has passed to enable unanticipated defects to be found and addressed. From a technical perspective, one of the advantages of the reset is providing time for optimization of the system and associated technical processes. Improving system reliability, resiliency, and availability remains a critical focus, and VA continues to monitor and enforce contractual SLAs. As part of the contract renegotiation of May of 2023, VA increased the SLAs tied to concrete financial consequences related to technical performance and end-user experience. There are now 22 SLAs and 6 service-level obligations in place to hold Oracle Health accountable. As a result, VA saw improvement in these metrics. As my colleagues in the panel, as my colleague on the panel, Bill Tinston, will attest, VA works collaboratively with DoD and the Federal Electronic Health Records Modernization Office to improve operations based on lessons learned. Based on our shared learning, we applied improvements where possible, such as improving certificate management, establishing Citrix pods that increase flexibility in system performance, and optimizing virtual private network setup for laptop computers. In conclusion, veterans remain at the center of everything we do. They deserve high-quality health care that is safe, secure, timely, veteran-centric, equitable, evidence-based, and efficient. With the activities and improvements that are now underway, VA leaders are optimistic about the eventual success of the current program reset, the deployment of level FHCC in March of 2024, and the future full implementation of the federal EHR throughout VA. Having said that, we will not do this until the system is ready to provide a good quality experience to users. I again extend my thanks and gratitude to Congress for your commitment to serving veterans with excellence, and we're happy to answer any questions you may have.
Thank you very much, Mr. Del Bene. The written statement of Mr. Del Bene will be entered into the hearing record. Mr. Tinston, you are now recognized for 5 minutes to deliver your opening statement.
Chairman Rosendale, Ranking Member Cherfilus McCormick, and distinguished members of the subcommittee, I thank you for the opportunity to testify today on our partnering efforts to get the federal EHR's deployment, implementation, and performance right. I'm accompanied today by Mr. Lance Scott, the Chief Technology Officer for the Federal Electronic Health Record Modernization Office, also known as the firm. On behalf of the firm, I want to thank Congress and the subcommittee for your unwavering dedication to ensure our nation's veterans, service members, and beneficiaries receive the safe, reliable, interoperable, and modern EHR they deserve. The firm performs a key role in the federal EHR modernization effort. The firm oversees the shared environment containing the federal EHR and support systems, governs the configuration and content changes derived through a joint decision-making process, tracks and facilitates software upgrades and solutions to optimize EHR performance, and informs continuous improvement through the tracking of joint risks issues, opportunities, and lessons learned. I understand the concerns regarding the reports of outages, incidents, and other technical problems associated with the deployment of the federal EHR. The effort to deploy our modern EHR has been and still is a challenging endeavor, but in no way do these challenges mean that the EHR modernization is not an attainable goal. The firm and its department and other federal partners work through these challenges every day. The modern, interoperable federal EHR is large in scale and complexity, but this scale and complexity deliver capabilities that enhance patient care and provider effectiveness. This federal EHR implementation effort also delivers on the promise of seamless healthcare transitions for service members and veterans, and establishes a single lifetime longitudinal record for beneficiaries. The federal EHR is an ecosystem of orchestrated technologies. The overall EHR modernization effort is not about a single product, network, interface, or application. Rather, it's about all of these products, networks, interfaces, and applications working together within a national enterprise. The national enterprise that creates the right circumstances to deliver the right experiences for clinicians and beneficiaries alike. This modern enterprise EHR capability enhances healthcare delivery and delivers better outcomes. Among its many benefits, the federal EHR allows for standardized workflows, provides better coordination between the VA and DoD and our other partners, and enables efficient dissemination of innovation technology and new capabilities. Although the federal EHR enterprise is not yet at the performance threshold we demand, improvements are occurring. Performance improves by looking at the entire federal EHR from an enterprise perspective. This holistic approach delivers a significant outcomes to an ever-evolving system. For example, the mean time to restore has improved by 50% over the past 18 months. Over this same 18-month period, healthy minutes were sustained above 99.5%. With an enterprise-wide approach to driving outcomes, we have also enhanced the stability of the Defense Enrollment Eligibility Reporting System, also known as DEERS, the interface with the federal EHR. These changes have had significant impacts, and over the past 23 weeks, DEERS had a single outage that was resolved in less than an hour. The firm, alongside its VA, DoD, and other federal partners, continues to collaborate and drive enhancements in the federal EHR. Since the initial deployment of the EHR, the firm and the departments have worked with end users and stakeholders to identify issues and improve systems reliability, functionality, usability, and capabilities. Collectively, the firm, VA, DoD, and our other federal partners share problems, learn from each other, and develop solutions together. There are tremendous advantages in this, and it results in a system that continuously improves. In closing, as the son and brother of veterans and a leader of an organization largely comprised of service members and veterans united in modernizing the federal EHR, this mission is personal and critical to me. I'm focused on delivering patient-centered care and providing the greatest capabilities available to support the most informed clinical decision-making. It's my observation that the more VA and DoD and our federal partners collaborate and team as an enterprise, the more we raise the performance of the federal EHR. I thank you for your commitment to getting the EHR modernization right and for the opportunity to speak to you today, and I look forward to answering your questions.
Thank you very much, Mr. Tinston. The written statement of Mr. Tinston will be entered into the hearing record. We will now proceed to questioning, and I recognize myself for 5 minutes. Unfortunately, Oracle is using the taxpayers' money and our veterans for their own private research and development mechanism. And it is very disappointing to this committee, and we see it time and time again. These companies hold themselves out to be the experts in the field, that this is exactly what they were supposed to be doing. And yet, we're being used as an experimental lab. And the taxpayers are funding it, and the veterans are the ones shouldering the problems. So downtime has been redefined. Service tickets aren't even being sent in anymore because there's been so many of them, and they have frustrated the employees so severely. And you know it, Mr. Delbenny. You know it yourself. They're not sending in all their tickets. Money is still free-flowing to Oracle. They're making billions of dollars, and it's, again, very disappointing. So, Mr. Delbenny, how do you explain the discrepancy in your uptime statistics versus the class survey?
Thank you for the question. I'm not familiar with the exact methodology for the survey. One distinct difference is it's a survey of people's opinions of how the system is doing. We do hear from people that are using the system, and there's frustration. I'll acknowledge that straight up. At the same time, we have a set of metrics that are actually measured based on the true system performance, and that suggests that progress is being made. We're not happy with the complete progress made, but we actually are being very systematic about measuring core system uptime, how systems around the core are performing, and user uptime and how often that they see a glitch. And we are seeing improvements in each of those metrics. But again, I'll
Okay,
acknowledge
Mr.
that that's-
Delbenny, when we see improvement going from 7% acceptable to 10%, on the paper, it looks like there was a 38% improvement, okay? But 38% improvement from 7% just to get you up to 10%, quite frankly, Congress has a higher rating than that, and it ain't really good, okay? So how is it that the system can be up over 90% of the time, and yet only 26% of the employees say it's available when they need it?
The core system is up over 99 point, or
Okay, so the system is up in totally, the entire system is up 97% of the time, okay? But we are also finding out now that that is based upon a 24-hour day. It is not based upon an 8-hour workday. So when you compress this down to an 8-hour workday, okay, and you take out the 10% of the time that it's not actually functioning, that's about an hour a day that the system is not. Mr. Delbenny, this is a simple math, okay? We clarified that this is based on a 24-hour day.
That's correct, but the probability, the actual downtime in a day under that statistic would be nowhere near an hour.
Well, Mr. Delbenny, I'm just working off of the numbers that we have here. If the numbers are based on this 24-hour day, and most of the medical centers are only open from 8 to 10 hours a day, aren't the numbers inflated so that no one is even trying to, when no one is even trying to use the EHR?
If I may, number one, the actual core system uptime is a very high number today. So they will
Mr.
not be-
Delbenny, if the number is being based upon, and the surveyor is being based upon the number of hours that the facilities are open, that is dramatically less than 24-hour day, correct?
Keep in mind that many of these
Mr. Delbenny, is that correct?
No, it's not correct.
So the system is going to be functioning 24 hours a day, but we only have people who are utilizing it 8 to 10 hours a day.
Well, with all due respect, that's the part that's wrong, because if you take someplace like Man Grandstaff, it's open 24 hours a day.
But how often are the people using that system? Do I need to go in and pull the actual hours and the charts for how many employees are utilizing that system? Because we'll pull that information as well. And I do not believe that you're going to show as many people working on that system, okay, from a 9 to 5 as you are going to be from a 8 p.m. until 4 a.m.
If I may step back, the measurement is independent of the people using the system. It measures it when it's being used by a lot of people, and it measures it when it's being used by few people. And the statistic covers over across all of those scenarios. And so the distinction actually, I don't think, is a material one in this case.
Mr. Delbenny, if no one is there using the system, okay, then you
measure
cannot gather information from
No,
it.
we actually still measure uptime in that case.
How can you measure uptime when no one is even trying to use the system?
Because it's
I will yield now to Ranking Member Surface McCormick. She can take on her questions.
Thank you so much, Mr. Chairman. I've worked in healthcare for a long time before coming to Congress, and I wanted to make sure we put the conversation in perspective. I think it's very easy for us to forget that this is not just an IT system, but it's really an electronic health record. So my question is for Assistant Secretary Delbenny. What are the consequences of an unstable EHR system in the healthcare setting?
Well, thanks for the question. We obviously want the system and are driving towards the system being at a very high level of reliability. The core system is what's most important to have correct and to have always up, and that's why we've driven a very high level of SLA, service level agreement, for that core system. The other systems that surround it, there are downtime procedures for.
I wanted to focus specifically on the consequences of an unstable EHR system in the healthcare setting. setting?
So-
Let's just identify, what are those consequences?
I'm not sure I'm actually the perfect person to answer that question since I'm not a clinician myself. We're striving towards having a high level of reliability both for the core and the surrounding systems as well.
So as you're implementing the IT standard in the contract, are you aware of what the consequences are, or what angles of it are the most important? Do you have awareness of that, or does anybody else have awareness of that?
When we do triage of incidents that come in every case we ask the question of, are there downtime procedures that people can use to accommodate or adjust to the fact that there's an outage?
Okay, so you have no understanding of the consequences when it's unstable.
I basically ask the people that are experts in that particular topic.
Okay, and how do EHR system failures impact patient care and safety?
Would you repeat the question, please?
How do EHR system failures impact patient care and safety? What is the impact?
Again, I don't think I'm the subject matter expert in that to be able to answer that question. I will say that we focus on having downtime procedures for every place where the EHR would be used.
So if you don't understand the implementation of it or the implications of it, how do you feel confident with the implementation of it? If you don't understand the consequences or the safety measures that are potentially harmful?
I do understand the system itself very deeply. I rely on people that are subject matter experts in the particular clinical workflows to make sure that the requirements that come into the system that we implement or the team implements will implement the right workflows.
And so I'm sure you had these conversations with the experts before, and you had the conversation of the consequences and the seriousness of this. So in your perspective, just recalling what they've talked to you about, could you please tell me those consequences?
I'm sorry, again, I think I'm
The
probably
reason
not
why
the
I
right
keep bringing
person
it
to
up is
answer this
because
question.
I've worked in the healthcare setting, and when we've contracted out, and the people who we had who were actually responsible for implementation did have an understanding of the basic needs and consequences so they can look out for it. Independently, without those understandings, how can you be confident that the implementation going forward is actually protecting those involved and also meeting the needs? I understand that you're staying on uptown, downtown, downtime also, you're looking on that. But is there any focus on the consequences, specifically in a healthcare setting, that you yourself have been exposed to? And it's important we get that answer because that would help us become more confident with the process you're implementing.
Thank you for the question. I think I understand the question. What I'm trying to say is that we act as a cross-functional team where physicians and experts in medical care work hand in hand with us so that the team makes sure the right things happen.
So you're not taking time to understand it yourself. Okay, so my next question for you is, what is the industry standard for EHR uptime?
Our goal is to have a 99.95% uptime. We actually believe that is at or above the core industry standard.
So the original contract set a standard of 99.9 when it was renegotiated early this year. It was raised to 99.95. Why do you think that this contract is still below industry standard?
Actually, for the core uptime, as we said in our testimony, it is actually achieving that standard.
So are you feeling confident with the performance of and the implementation of Oracle?
Overall, no, we still think there's a ways to go. I don't want to present the system as all set and ready to go. There are places we have significant concerns that we're working with Oracle on, so I want to make sure that's clear. The incident free time not hitting standards is important. The end user responsiveness, we think, still has ways to go. We think there are functional workflow issues that still have to be resolved.
So it's my understanding that the industry standard is 99.99, and the standard set forth by the renegotiation is 99.95, which is below industry standard.
I don't think that's the case, but we should take that for the record and do some research there. 99.99 is typically a standard used for an infrastructure component like identity management. An end-user-focused system will tend to be more towards 99.9 or 3 nines in reliability, and so we wanted to push it higher than that and get to 99.95. One of the things to keep in mind is, again, the downtime procedures and being able to work with the EHR down will also influence whether you push that vendor to get towards a higher standard or not.
Thank you. I yield back.
Thank you very much, Representative Sherfless McCormick. I now recognize my good friend from Texas, Representative Self, for 5 minutes questions.
Thank you, Mr. Chairman. I heard you dismiss the opinion of employees in a survey because there are people behind technology. And frankly, the VA system is a people business. They are real people administering care. They are real people receiving care. So in this survey, and I want to use the survey even though you may dismiss it, when 9% say that the Cerner system makes them as efficient as possible and 10% say it helps them deliver high-quality care, the question is that a failure of the system? I suspect you will say no, and if that is the case, if your answer is no, what percentage would be failure?
Thank you for the question. Actually, I don't dismiss the survey. I think what I said was I don't know the methodology of the survey. Having said that, I actually hold in very high regard the opinions that come from end users. They're the ones that matter. And so if they feel like the system is not meeting their needs, we have to rectify that situation. Full stop.
So what percentage
I'm sorry.
would constitute failure of the system?
What percentage would constitute
If
failure?
9 and 10 do not, what do you think the system is a failure at this point of time, at this point in time?
I would say that having 9 out of 10 people not be happy with the performance of the system is a problem.
Okay. Dr. Pertula, continuing with this survey, 8% said their initial training prepared them to use the system. 14% says the training was helpful. Is this a training problem or a system problem?
Thank you for your question. In terms of training, end user training, there are some, that's not part of my responsibilities, but we are focusing on that training with some of the EHR-MIO components. In terms of is it a failure of the system in terms of how you use it, we are making every effort to ensure that training is changed, to ensure that we understand what the users need, what kind of potential additional training or different kinds of training we can have with them. So additionally, we are also working with our IT, local and OINT, to ensure that they are absolutely understanding what the systems are, how they operate, and who to call should there be any issue.
Can you tell me why the employees in the private sector do so much better with the Cerner system than the VA system?
I can give you an example of, or an idea of, we have a multitude number of changes that we have introduced into the code base or the main Oracle stack. And so VA has significantly customized that platform. And so what we're doing right now is bringing back many of those customizations to make sure that we're coming back to the base of what the system is supposed to do. Most of the commercial entities, or as I'm told, use out-of-the-box functionality from Oracle Health. We have significantly modified that code base. But as I said, we're working to bring that back into standards.
I would question that, use it out of the box, because I think most people have some customization. Mr. Tinston, I didn't understand your reference to DEERS. DEERS is decades old. What is that tie that you tried to make?
Into other DoD systems. DEERS in particular has posed a problem for operations on the VA side because calls were made to that system, and as you described, it's an age system, and so its performance impacted the performance of the VA experience with the EHR. The VA has changed their interaction such that they've created resilience from an EHR perspective, so that if there's a DEERS problem or a connecting system problem, that their users are able to continue with the work and the workflow that they were engaged in. And Mr. Del Bene has engaged with the DoD CIO to drive improvement in the associated connected DoD systems such as DEERS.
Okay, Mr. Chairman, I yield back.
Thank you very much, Representative Self. Mr. Del Benny, I'm gonna go back and try to pin down a little bit more information about the discrepancy between what is actually being reported and through Oracle and what is the employees are stating, because we've got this big gap, okay, between how bad they say it is and how bad that you guys say it is. So the incidents that are experienced by the employees, crashes, slowdowns, hangs, all of these things are severe enough to the point that the employees find the system unusable, okay? So if an employee finds this system unusable, what I'm trying to figure out is, how are you reporting that? So they report it to you and they say, I've had this system, it's unusable at this one facility, at this one site, okay? How does that get calculated in for this 97%, 98% showing that it's up and running where we have these downtimes, again, based upon an 8-hour day and one facility instead of all of the facilities and a 24-hour day? How do we do the reporting for a person sitting at a desk and saying, this system won't work for me for an hour?
So again, the measures that exist are 24-hour wide measures. That there's no concentration of those in a particular 8-hour period. So I think that's part of our discrepancy. Now, but let me step back. We definitely think that there are issues around getting good performance or end user responsiveness still in the system. The three measures that we've defined as SLAs, which, without going into much detail, get to the average responsiveness, the 10% worst responsiveness, and the 1% worst. So we were very careful to make sure we had all three of those. In each case, they're hitting it, but in the particular for the 1% of people, there's still a lot of hangs that happen in the system, as we define a hang as a 5-second pause. And so what that metric is, the threshold is 50 of those in a day. The current number is somewhere around 20 of those in a day. I actually think if you were looking at the screen and seeing 20 such hiccups, if you will, in a day, you would perceive that as unacceptable performance. And so I think that's a place where we actually are aligned and we need to do better. The other thing I would make clear is we particularly set up the contract so that as we go into additional option years, we can change those SLA numbers and we can ratchet them down to be more strict. And so we're looking at those SLAs and saying which ones would we change moving forward.
So again, this gets down to the definitions and it gets down to the math, okay? Mm-hmm. And I think that that's where we have the big problem, because if you're having this problem, the same problem, the hang up, the delay, and it's taking place in different facilities at different times throughout the course of the day, then it's not really getting calculated accurately about the system having a deficiency, because we are basing it on a 24-hour day, and you and I can debate back and forth, but you're not going to have the amount of traffic on that system from 6 or 7 p.m. until 4 a.m. that you have from 9 to 5. Okay, so moving on. Only 11% of the VA employees told the class research that the Oracle Cerner EHR has the fast response time that they expect when logging in, refreshing the screen, and retrieving the information. That sounds a lot like the definition of incidents, yet you're reporting incident-free time in the high 90s. Again, how do you explain that?
Well, thank you for the question. We know for each of the systems whether they are responded or not, and we separately measure what's the actual response of the user experience. And so what you see is the number, we can actually measure whether a particular system is up, and we can accurately measure as a result how much incident time there is in aggregate. We separately measure whether the actual system is responding adequately. And that's the number I tried to give you a sense of. They're meeting the SLAs, but we still think, particularly for that 1% of users, which probably will be more vocal, and rightly so, that the experience may well be unacceptable.
Mr. Del Benny, if your definitions are not capturing problems with the AHR that are preventing the VA staff from doing their jobs, okay, they're just saying, this isn't working for me, and you don't have a definition to capture that, doesn't that mean the definitions are incomplete or not accurate?
I think it means that we need to really make sure that we're well aligned with users to make sure we have and we are, to make sure we understand how they're perceiving the system. There's two separate questions. There's the performance of the system and what do the numbers tell us? And then there's how end users are
If I file a
perceiving it.
complaint, let me make this real simple. If I file a complaint and you're speaking a different language, okay, that doesn't accept that complaint, then it's not getting registered. Representative Sherfless McCormick, I would recognize you for your next round of questioning.
Thank you so much, Mr. Chairman. I have huge concerns as I was considering the conversation we just had. One of my concerns is, I'm trained as a lawyer. I don't have a healthcare background when I got into healthcare, but one of the basic things that we do is to understand the healthcare system. The reason why it's important to understand the healthcare system is because you have to understand if you're actually weighing the right variables and if you're actually weighing the right matrices to determine success. And so the end users of Cerner and Oracle, I want to know what your relationship is with them because they do understand the healthcare system and they work together. Now, do you have any system or a survey that you may have used to find out what their perceptions are? Because what you're reporting does not match what they're reporting.
Thank you for the question. It's a very good one, and we do those end-user feedback sessions as well as surveys. So let me pass to Dr. Pertula, who can talk more about that.
Yeah, so thank you for the question. We do recognize that we recognize that we needed to be much more close to our end users, and so we established during this reset period, we established some integrated teams with VHA and our groups in EHRM to really assess where are we in terms of the user experience. So we have human factors engineering groups working with us now to make sure that, and with Oracle Health as well as our partnership, to make sure that we start working on remediating what the users are understanding that needs to be improved from an end user perspective. We also have from some surveys that the pre and post deployment of a code block, which is a major release. We have some of those that we started to do to understand where we are in terms of to the experience that the users are having with that.
So could you please provide us with those surveys and that data? How frequent is that, those surveys?
We just started that.
You just started
with a code
So how
block.
many rounds of surveys have you conducted?
One.
One round of surveys?
Yes.
When was the last survey that was conducted?
That was with our code block release 9, so that was in September
In September of this year?
of this year, yeah.
And who does the critical analysis of that, the surveys?
We're working, like I said, with human factors engineering and VHA.
And so when are they delivering the results of that?
We're looking at those results now.
And so once you receive it, how are you planning on doing the critical analysis of what they deliver to you?
So we have projects established, so as we go and do the root cause analysis as to what is going on, what did they identify as being an issue, we go and evaluate where should we be starting, and we have projects that we can kick off to go and address each one of those.
So will you and Mr. Del Benny be a part of the critical analysis?
We work as a partnership, you know.
Okay, so then could you tell me what the consequences are of a failing EHR system?
I cannot tell you the consequences, I'm not a clinician
So are
either,
you
but
substantially confident that you can, in fact, be able to do that critical analysis if you don't understand that?
like I said, we're working with VHA as well in that evaluation. So it's a
So you're relying totally on their analysis of it?
It's a joint analysis because if it's like the front end portion of it, that's with our VHA. But if it is something that the system can enhance or can fix, that's where we come in as engineering and architecture.
So do you feel comfortable knowing that that part of understanding the basic part of healthcare, the necessities, the safety for our veterans, that lack of knowledge, are you comfortable making decisions without understanding the implication on our veterans?
When we look at the requirements that are given to us from our functional community, we work with them on every step of the way.
So you are comfortable with that, knowing that a failing system can cause death and safety hazards for our veterans. Are you comfortable with that?
No, I'm not comfortable, and I didn't say that.
So I guess what I'm asking is the relying on, well, you can go ahead and answer, Mr. Del Benny.
Yeah, I think we've gotten a little off track here. I think what we're trying to express is that we act as a cross-functional team, multifunctional team, and in the end, what matters is that the team concludes, Are we ready to continue past
We're
the reset or
We're
not?
actually right on track. I didn't want to step in, but we are on track. And as I said, as leading a healthcare company, there's a certain amount of reliance that you can have on your team, but as a leader, you have to understand certain principles. Understanding the consequence of the people who you are protecting and carrying out the mission of taking care of our veterans is an important mission, but understanding the critical nature of the system is also important. And that is the baseline, the mere baseline. So understanding that is one thing, and ensuring that everyone who's working on the team understands that is another thing. So I wanted to see, I'm trying to become more confident about the structure and what's present. And the more we talk about it, the more confidence I'm losing, because I'm not seeing that independent process of understanding the basics. These are the basic systems that aren't being understood. So I'll just yield back, Mr. Chairman. Thank you.
Thank you very much, Representative Sherfless McCormick. I will now recognize my friend again from Texas.
Thank you,
Representative
Mr.
Self.
Chairman. I want to go back to those end users. I assume those are your employees and not the veterans. So what are they instructed to do when they have either a shutdown or a, what did you call it, a pause, a 5-second pause or more? What are they instructed to do? They're with a patient. And the system becomes unusable for some period of time. What do they do?
So we have, again, in that collaboration with our Veterans Health Administration working groups, we notify employees when there's an issue, either that they have reported or that we know that the system is not executing where it needs to be. We have a process in place where we can notify them. This is what's going on.
We're sitting in the room. You're getting an exam or whatever, and the system is unstable.
So
Do they use it during the actual clinical treatment? Or is this only a planning system? I assume it's used during treatment.
If I may, if the system, again, the uptime for the system is such that for the vast majority of the time, the system is operating these days. So we should just be clear there. If there's a system issue, incident going on, they have downtime procedures which allow them to continue to do their work.
Okay, so you said your average is 20 of these. What'd you call them, pauses?
So you're saying, yeah, so for the average person, it's, I think that Laura can tell me, 2? So the statistic for the average person is 2 such instances of less than 5 seconds in a particular day.
Okay.
So that actually won't
So
significantly.
you don't think it impacts the quality of their care
I
at
think
all?
the 1% is the place we need to really focus. So the 1% of users that are seeing the worst possible experience are still seeing 20 such incidents in a day on average. And that's unacceptable.
Yeah, so the VA, the Dallas VA is in, it's not in my district, but it's close to my district, the second largest in the system, I believe, 200,000 veterans. So the 1% would be a significant number of veterans that would.
It would be end users, I'm sorry, that would be the 1% of the people operating the system.
Operating the system.
Yeah. The other thing I'd like to be clear on is the place that we've had best progress so far is actually in the clinician experience. So and particularly in this last block upgrade, their experience has improved the most. It's around registration and scheduling that we probably have some issues. We have more issues centered on that end user group.
Okay, Mr. Chairman, I yield back.
Thank you very much, Representative Self. Mr. Delbany, you acknowledged in your testimony that the EHR is not meeting veterans and VA clinicians' expectations. Activities to prepare for the go-live at the James A. Lovell Federal Healthcare Center in North Chicago are underway right now. Does the system meet those expectations now? And if not, how's it going to improve by March?
Thank you for the question. We are not at a point that we're launching today. I think we believe we're on track to launch in terms of the expectations of the people managing the system in Lovell. But I actually might ask Mr. Tinson to reply on that one if you are okay
Please.
with that.
Representative Rosendale, we work every single day cross-functionally with the technical team at the VA, technical team at the DoD, the 2 programs, and the leadership at North Chicago to make sure that we're on track to deliver in March. And our understanding and our intent there is to get a yes, that we can improve their ability to deliver care before we go live with anything in North Chicago. I expect that answer will be yes. I have no reason to believe it's anything but yes at this point, but we're diligently watching every single day.
Okay, Mr. Del Bene and Ms. Pertula, you should be familiar with the EHR reset legislation that was provided to the VA in September.
Yes.
Okay. It would establish criteria for each medical center director to certify that the Oracle EHR is appropriate to install and the facility is prepared to receive it. The bill isn't law yet, but this is a common sense standard. Are you going to apply the standard to Lovell without the legislation, and do you believe that Lovell would meet it?
I believe that it's important for the end users and for the management of that facility to be on board and supportive of the rollout.
Okay. I do too. That's why we have that language in the legislation. So what I'm asking is, are you ready to apply all of those standards to the Lovell rollout, and do you believe that they would meet it?
I believe at this point we're on track to meet that when we do launch, but we won't launch until we've met the standards that are part of our go-live criteria.
Mr. Tinston, Mr. Scott, James Lovell is the only fully integrated DoD VA hospital. You're implementing the Oracle Cerner EHR there before VA can finish their reset work. What unique challenges does Lovell pose, and how are you going to overcome them? This is a facility that is different than any other place we've had a rollout. So again, what are the challenges, and what do you think that needs to be done?
Sir, the problem is different at James A. Lovell Federal Healthcare Center. They're an organization led by the VA that was asked about a decade ago to work in an integrated fashion, supporting both DoD beneficiaries and VA beneficiaries out of one common facility. We didn't equip them with the right IT tools to do that. They use at least 3 different EHRs trying to create integrated care delivery at that facility. So we're solving that problem, and we work every day, to your prior question, with the director of the facility to make sure that we're addressing the problems and we're making things better as we approach a go-live at that facility. That is the last remaining DoD facility. It's the only one they haven't deployed the common record to. And we work every day, and to your point, specific issues to there, are that they see beneficiaries from both systems every single day, and they do that in an integrated fashion, and we have to improve their ability to do that. Because the people there have already done the work in working in an integrated fashion. We need to give them the tools. That's what we're striving to do.
So I have grave concerns because of watching the other facilities and the rollouts, and we know that Lovell is a lot more complex. And forgive me if I'm a doubting Thomas about this, but when we see the deficiencies and the failures in the other facilities that are not nearly as complex as Lovell, again, we're going to need to apply these matrix. If the legislation isn't passed, I'm hoping that we can get you to agree to this matrix, but right now as you look at it, what level of comfort do you truly have that we're going to be able to meet those matrix in March?
So it's actually pretty high. It's the highest it's ever been, and it has improved every day in the last year because we work on a daily basis with the leadership team that delivers care at FHCC in North Chicago. And so as we continue that engagement, and I had our situation report with the broad team yesterday afternoon, and there were no showstoppers. But this is led by the VISN. We have the VISN there, we have the director of the facility there, we have the Veterans Health Administration there, representatives, in the conversation every day to make sure that we're meeting the criteria that they need to go live and deliver effective care and safe care better than they do today.
Thank you. Thank
absolutely.
you. Okay, I'm going to yield to Representative Sherfless McCormick. Thank you.
Thank you. Mr. Tinston, what do you see as the firm's role in improving system stability for VA and the DoD?
So the firm is about the things that we do together between the DoD and the VA, not things that we both do, but things that we do together. So the firm, by charter, is set up to manage all of those joint processes. So part of your question, yes, ma'am.
Are there any factors that limit your ability to succeed?
So we work within the boundaries that the two departments have set for us. I don't know that anything limits our ability to succeed. No, ma'am.
This is a little off the topic, but since I have you here, in May of 2022, the VA and the DoD Inspector General published a report that found that the DoD and the VA did not take all of the action necessary to achieve interoperability because firm program office officials did not develop and implement a plan to achieve for all FY 2020 NDAA requirements, or take an active role to manage the program's success as authorized by its charter. So my question is, what is the status of the firm's efforts to address this recommendation?
Ma'am, with regard to that recommendation, the two deputy secretaries whom I work for, Deputy Secretary of VA and Deputy Secretary of the DoD, asked me to come back with our plan to address that. And I've done that, and what we're doing is focusing at this point on the joint site at FHCC, because that is the culmination of all our efforts to create a joint single federal record.
Okay, so when do you plan to be fully compliant with the NDAA's driven recommendation?
Ma'am, I believe we are.
All right, I yield back. Thank you.
Thank you very much. Mr. Tinston, why isn't there any survey data for the MHS Genesis for this year? Did the DoD decline to participate?
Not that I'm aware of. So the firm works with both departments to include EHR-related questions in surveys that the departments were already doing. And interestingly, we just completed, as NDAA 2020 requires, an annual EHR summit with users from each department. And the results of that will be coming out soon. But in general, what we got from the users was that they recognize the importance of the EHR. They think that things are improving. Their complaints were, as you noted in some of your questions and comments, that the training's not right yet, that we're not quite there, but we're moving the right direction. And we're compiling the results of that EHR summit, where we had 1,000 users participating with us for 2 days. And we'll have that available in the near future.
I would love to see that survey information. And again, when we show improvements and you're going from 7% satisfaction rate to a 10% satisfaction rate, as a percentage, that looks great, but it's really not that much of an improvement. I mean, I am sorry. And when we also are taking calculations on downtimes, slowdowns, and things like that are for one person, one facility, and we aren't even gathering in all of the tickets any longer that we know that are out there. That doesn't give us confidence about the working system either. Mr. Tinson, last year, only 24% of the military health system employees told class that EHR was available when they needed it. That's even worse than the VA. Is that what we can expect at Lovell?
Absolutely not. I can't speak to what people will say, but when we look at people's satisfaction surveys on an enterprise system, we have to consider multiple factors. It's incredibly important that they be satisfied and that we do everything we can to create their ability to effectively use the system and ensure that we deliver an effective system.
And again, the surveys are showing that the people are not satisfied with it, and Mr. Del Benny can say that the system is up and functioning, but again, I continue to go back. If it's up and functioning because nobody is utilizing it, and it's between 8 p.m. and 4 a.m., then doesn't really matter. It's when people are there trying to utilize it. Dr. Petula, here's the most troubling response from the Klaus survey. Only 10% of the VA employees said that Oracle Cerner EHR enables them to deliver high-quality care. Only 10%. I will grant you, that's up from 7% last year. Again, I'm going to these percentages. But these numbers are abysmal, and compare that to the number for Vista, which is at 56%. We're talking a dramatic difference. How many billions of dollars more is it going to cost to get the Oracle Cerner number up to the Vista level, and how long is it going to take us to get there?
Thank you for the question. We are working very closely with Oracle Health in terms of improving system performance in general. And we have made a number of improvements since I've got to this position. We have at least 47 different projects that we have been executing, and around 36 of them we have been completing.
Ms. Pertola, I hate to interrupt, but as you know, we only have a limited amount of time. We're approaching $4 billion spent on this system, okay? It's been in place since I've been here, so my tenure's been coming on 3 years now, and I know that it was on before that. So how much more would you say that we should begin to have conversations about allocating towards this system, and how long is it going to take us to bring those numbers up to where Vista is today?
I think that you will see improvements in the coming deployments that we have. I cannot tell you when we're going to be reaching the same numbers as Vista, but I am very confident that we will be able to get to numbers that are going to be acceptable to our end users.
Okay, I still have a little bit of time. At this rate of improvement, it would take Oracle EHR 15 more years to come up with the level of Vista. 15 years, based upon the incremental changes and improvements that you all have been making. Do you think that that is reasonable, and is that worth investing in?
Thank you for the question. I believe that with the changes that we are bringing on, we're starting to get more velocity on the changes, and we're trying to ensure that all of those, in every release, we have a performance improvement. I believe that it's not going to take us 15 years to get to the Vista performance.
Thank you very much. Mr. Landsman, I would defer to you, yield to you for 5 minutes of questioning.
Thank you. Thank you, Mr. Chairman, and thank you all for being here. You all have gotten into a lot, so let me just ask a couple high-level questions. And this is for Ms. Del Bene. I'm curious, because this is obviously not the first time you've taken on something like this. I'm curious about the approach. I mean, this highly complicated system that has a whole host of very serious issues. This is a big picture. How do you approach something like that? And as it relates to the larger problem, but then if you drill down to the sort of end user, the staff, and those they care for, in this case, veterans. What is your approach? What are the big North Stars? How do you tackle something like this?
It's a good question. Thank you for it. I have experienced a lot of these sorts of systems in my career. I think first you have to be anchored on whether you believe the system is addressing end user needs directly. Is it a good fit for the system relative to what you're trying to accomplish? At that point, you have to make sure that you're taking the feature requirements that you get from end users, and are you on a good path to actually implementing them in software, in the system? At some point, it gets down to a period of winnowing down the changes until you get to a point where the system is stable. If you feel like you've addressed the end user issues, you then drive down towards what we would consider a release of that software. That's probably one of the most uncertain times in the system, because you just don't know what, as we say, the tail looks like. How long is that tail going to last? The reason we set up the reset the way we did is because of that uncertainty of how long is it going to take us. And we're committed not to actually start to deploy again until we get into that chute, into a place where the end user experience is good. And so that's the challenge we have in this system in particular. I want to just acknowledge again, we don't think we're there. We don't think we've got everything done that we need to get done for the system to be acceptable to end users. We are committed to not deploying in further locations until it is.
So, it's very helpful. So there's sort of these two things, or at least I picked up on two big things. One is you got to get to a place where does this work for the end user? And then if the answer is yes, you start working through the problems and, until you knock them all out. And you are at this point where you're trying to sort out whether or not this is, or how do you get to a place where this is a good fit or this works for the end user. What are the 2 or 3 big things you're looking for? I mean, what will not exactly the things that have to happen, but as you're you go in every day, what are the things that you're monitoring as it relates to, are we heading in the right direction in terms of this being a good fit for the end user?
Well, there are other parts of the team that are saying, how are we doing in terms of the clinical experience? As a technical person, the pieces that I'm looking for is, does this system look stable? Are we making progress on those things we're managing? I'm also looking to the team and saying, when I triage, or I meet every morning, we walk through every incident that had happened in the past 24 hours. The thing I'm looking for is patterns. I'm looking for, does this show, are we doing enough due diligence and change control? Are we causing incidents because of the change that we shouldn't? I'm looking beyond it and saying, is there some instability beyond this that is this is a telltale for? So I'm kind of looking at the entire system and saying, what's the so what? What are the hidden things behind this that this might be an indicator of? And trying to look deeper into the system every day. And then there's the metrics of just success. Are we, on those SLAs that we defined, are we actually hitting them on a regular basis? It's one thing to hit them once. You got to hit them on a sustained basis to feel like the system is truly stable.
And last question, how long do you give this? I mean, and that's not a got you question. I'm just in general, maybe not for this specific thing, but when do you start feeling like, okay, this may not be a good fit, or, you know what I mean? Like what?
I do.
Okay, are you at that point?
I think having done this a number of times, the first thing you look for is, are you not within some bounds of stability, like this thing is coming in for a landing?
Yeah.
I don't think this system looks that way to me. However, if you want to talk about how long that tail is, I think at this point we don't honestly know.
Got it. Thank you. Yield back.
Thank you very much, Representative Landsman. Thank you very much to all of the witnesses for joining us today. The panel is excused from the table. And I would yield to Representative Landsman if you have any closing remarks that you would like to add.
Just a few. One is thank you all for everything you're doing. This is incredibly complicated. It's also very, very important. As you know, I mean, this is your work right now, and for some of you, I suspect it's been your work for a long, long time. So I just want to say thank you. And I have a VA hospital in my district. It is a huge facility. It serves, thousands and thousands of people who served us. And, for them to get to a place where the system that they're using is helping them, in a way that the current system doesn't, right? Is it helping them serve the folks that they care so much about? And, it's just so important. So I just appreciate what you all are doing, and Mr. Del Bene for bringing your expertise, and I suspect it gives a lot of people a lot of confidence that you're here and you're sorting through it and being as deliberate and thoughtful as you clearly are. So thank you all. Thank you, Mr. Chairman.
Thank you. Thank you very much. Today's hearing should have been unnecessary. The very least we expect from a piece of software is that it runs reliably when we launch it. The complexity and the rate of change within the VA should be no surprise to anyone, and this is no excuse for Oracle. Again, they hold themselves out as the experts in this field. The irony is that the VA already has an EHR platform with more than 99.9% uptime. This is like ivory soap pure, folks. It's called Vista, and we delved into how it achieves that level of performance in March. It's baffling that anyone could pay billions of dollars and set a lower standard. But I understand the determination to make Oracle Cerner work, especially now that DoD has nearly finished implementing it. I hope the two departments and Oracle can put the blame shifting behind them once and for all and address the problems regardless of who may have created them. We're going to be giving special scrutiny to how the system performs at James A. level. At the joint facility, finger pointing isn't just counterproductive, it can be fatal. Once again, I want to thank the witnesses who appeared today. I ask unanimous consent that all members have 5 legislative days to revise and extend the remarks and include extraneous material. Without objection, this hearing is adjourned.